you can start the recording if Dr. Akerkar permits us.
Yeah, let's go ahead. No problem.
Great. I'm sharing my screen. Kapil, please confirm if my screen is visible.
It's visible, Dr. Sagar.
Thank you. Hello, everyone. Very good evening to each one of you. Myself,
Recording
Dr.
in
Sagar Panchal.
progress.
I am Senior Medical Advisor to Johnson & Johnson Immunology for India as well as South Asia. And on behalf of J&J, I would like to thank each one of you for joining into this session. As a leader in the field of immunology, especially the field of rheumatology, we always try to bring differentiated medical education events for our clinicians. And in the similar effort, this year we have introduced this new platform, which is Go First. We try and discuss and debate about the role of biologics, especially the TNF-alpha inhibitors, in the management of ankylosing spondylitis, and also to disseminate the data regarding the recently generated evidence of golimumab in Indian patients across different indications of arthritis. So with this context, I would be privileged to introduce today's speaker, Dr. Shashank Akerkar, who's one of the leading rheumatologist, clinician, and a researcher in this part of the world. He's currently practicing as consultant rheumatologist at a Mumbai Arthritis Clinic and Research Center. He is a recipient of several awards, just to note a few, like Young Scientist as well as the Young Clinician Award in the field of rheumatology. He is a faculty at international as well as national conferences. He has multiple publications to his name in various international as well as national peer-reviewed journals. He is actively involved in the clinical research in the field of rheumatology, and he is also passionate about the use of information technology to clinical medicine. So with this, I would like to welcome our speaker, our faculty for tonight, Dr. Akerkar. Welcome, sir. And just a quick update about today's agenda. So we'll have two sessions to be taken by Dr. Akerkar. First is about the role of TNFI inhibitors, TNFIs in the bio-naive SPA patients, followed by data on the efficacy and safety of golimumab in Indian patients. Post that, take all the questions, all the queries that our attendees have. So I would request everyone to please note down your queries, put it in the chat box or a Q&A section, and we'll take all your queries at the in the panel discussion. So with this, I hand it over to Dr. Akerkar. Over to you, sir.
Thank you, Dr. Sagar. Good evening, everybody. Great to be here digitally with all of you today. Is my screen visible?
Yes, sir. Please put it on the, full screen is visible. Please go ahead.
Perfect. So rather than just talking about the role of anti-TNF in ankylosing spondylitis or spondyloarthritis, I thought it would be better to understand the clinical part as well and understand why anti-TNF or biologics are important in ankylosing spondylitis. So apart from just the role of anti-TNF inhibitors, we would also be looking at what is the importance of, first of all, ankylosing spondylitis, some clinical details to get a perspective. What is the importance of early treatment initiation, and obviously the role of anti-TNF inhibitors. Let's have a look. First of all, spondyloarthritis, as you all know, is a group of related disorders that share distinctive geographic clinical features. It involves sacroiliac involvement and what differentiates it from other diseases. Peripheral arthritis and other arthritis and dactylitis, which again differentiated tissue diseases, and extra-articular psoriasis, inflammatory bowel disease, and lastly, B20.
Dr. Akerkar.
Differentiate spondyloarthritis, inflammatory arthritis. As you all know, this is the routine.
Dr. Akerkar, sorry to interrupt you. I think there is some issue, technical challenge at his end. He'll connect back soon. I would request everybody to just wait for a couple of minutes.
Dr. Sagar?
Yes, sir. Yes,
Yeah,
I can hear you.
Some issue at the Wi-Fi at my end. Sorry.
So there was some issue as well in terms of your voice. So can I request that if I can share the screen and then you can brief about it so that the bandwidth gets utilized?
What we'll do is let's start with this. If there is any problem, let me know. We'll do that.
Sure. Okay.
Yeah. I hope my screen is seen properly now.
Yes.
Perfect. So maybe I'll just go back to the first slide again. Spondyloarthritis, as you all know, is a group of related disorders that share distinctive clinical, radiographic, and genetic features. Clinical features because it involves inflammation of the sacroiliac joints and the vertebral joints. This is what differentiates it from rheumatoid arthritis and other connective tissue diseases. Peripheral arthritis and features like enthesitis, dactylitis, which are again characteristic of the spondyloarthritis group, and extra-articular manifestations and associated involvement like inflammatory bowel disease and psoriasis, which again differentiates it from the other group of inflammatory arthritis. Radiographic features which show sacroiliac joint inflammation and involvement of the axial skeleton. And lastly, a strong genetic association with HLA-B27. As you all know, it's a group of diseases, group of different inflammatory arthritis, the prototype of which being ankylosing spondylitis, which is a prototype of the axial involvement of spondyloarthritis, and the other ones including psoriatic arthritis, reactive arthritis, IBD-associated arthritis, and juvenile chronic arthritis, and lastly, undifferentiated spondyloarthritis. If you look at this from a different perspective, it can be differentiated into one, axial spondyloarthritis and peripheral spondyloarthritis. Axial spondyloarthritis would mean involvement predominantly or exclusively of the axial skeleton, whereas peripheral spondyloarthritis would mean involvement predominantly of the peripheral skeleton, the peripheral joints, as you can see here, and there would also be a group which would be a combination of axial as well as peripheral spondyloarthritis. Today, we would be focusing more on axial spondyloarthritis or ankylosing spondylitis. What do these patients come up with? As you all know, is inflammatory backache. What exactly is inflammatory backache and how is it different from the mechanical backache that you commonly see in your orthopedic practice? Inflammatory backache is because of inflammation of the sacroiliac joints and the vertebral joints. The age of onset is commonly a young patient less than 40 years, more than 3 months duration, insidious onset. It is associated with significant morning stiffness. And what differentiates it from mechanical backache is its improvement with exercise and worsening with rest. And another characteristic feature of inflammatory backache is nocturnal backache. When it comes to nocturnal backache, there are two types what the patients complain. One is difficulty in falling asleep because of pain, and second, falling asleep is not a problem, but patient tends to get up because of pain in the buttocks, the gluteal region and the lower back or any part of the back in the second half of sleep. So inflammatory backache, the difficulty in falling asleep can be because of various reasons including functional reasons, but what is characteristic of inflammatory backache is awakening in the second half of sleep, 4 o'clock, 5 o'clock, 6 o'clock, the patient tends to get up. Our patients are not very good while giving the history when we ask them about inflammatory backache. So what are the surrogate questions that we can ask them to get that exact information about inflammatory backache? Does the backache disturb your sleep? Do you find it difficult to turn in bed while asleep? Can you bend down to pick up objects in the morning? So many times they don't really understand the meaning of morning stiffness. So can you bend down to pick up objects in the morning? How do you get up in the morning? An ankylosing spondylitis patient will give you a typical history of, taking 10 minutes, 15 minutes just to get up and get going. Coming to the diagnostic part, now that we have a patient with inflammatory backache, how do we go about? How do we reach the diagnosis of action spa? We'll also look at why we are getting into this sometime down the line. Do we really always require a MRI to get a diagnosis of axial spondyloarthritis? Not really. In fact, these are the SS classification criteria for axial spondyloarthritis. If somebody has inflammatory backache, one, we can get a MRI done, and the MRI can, if it comes out as sacroiliitis, with sacroiliitis, you require just one more additional spondyloarthritis feature to get to a diagnosis of axial SPA. These features include dactylitis, psoriasis, positive family history of spondyloarthritis, inflammatory backache, that is the entry criteria that we just saw, NSAID with good response to NSAIDs, enthesitis, particularly plantar fasciitis, peripheral arthritis, Crohn's disease or IBD, elevated CRP, HLA-B27, and history of presence of uveitis. So inflammatory backache, if you have sacroiliitis on MRI, you are through with the diagnosis. Suppose you are not able to do a MRI or the MRI is normal, how do we go about? Still, if the person has inflammatory backache, the HLA-B27 is positive, and you have one more feature which is specific of spondyloarthritis, as you can see here, either sacroiliitis on imaging or HLA-B27 plus inflammatory backache and one more feature of spondyloarthritis, you are still through with a diagnosis of axial spondyloarthritis. So you don't really have to always depend on sacroiliitis on MRI to reach a diagnosis of axial SPA. When it comes to peripheral spondyloarthritis, a patient having only peripheral manifestation, there is no inflammatory backache, no involvement of the sacroiliac joints or the vertebral joints. In a patient with pure peripheral manifestations, if the patient has either arthritis or enthesitis or dactylitis, if the one more of these features, either psoriasis or inflammatory bowel disease or preceding infection which would suggest reactive arthritis, HLA-B27, uveitis or sacroiliitis on imaging, or two of the other features, enthesitis, dactylitis, inflammatory back pain in the past or positive family history, it is still sufficient to peripheral spondyloarthritis. You must have seen in recent times, rheumatologists, using less and less of the term ankylosing spondylitis, and you must have seen more and more use of the term called as axial SPA. What exactly is this concept? This is in recent times, this is the new concept that has evolved from ankylosing spondylitis to axial spondyloarthritis. So AxSpA or axial spondyloarthritis is the entire spectrum of spondyloarthritis when the axial skeleton is involved. So it is divided into non-radiographic stage and radiographic stage. So it is non-radiographic axial spondyloarthritis and radiographic axial spondyloarthritis. Non-radiographic would mean the patient has inflammatory backache and the MRI shows sacroiliitis, but there is nothing seen on the X-ray. X-ray is normal. So MRI showing sacroiliitis, but a normal X-ray would mean this is non-radiographic stage of axial spondyloarthritis. And if the X-ray shows changes of sacroiliitis, then it is considered as radiographic axial spondyloarthritis. What otherwise does this mean, and why is this classification required? Is there is a lot of delay. One of the biggest problems as far as axial spondyloarthritis or ankylosing spondylitis is concerned is a big delay in diagnosis. Globally, not just in India, but globally, the delay in diagnosis of AxSpA is almost 6 to 8 years. This happens because most of the times we were depending on the X-ray changes to reach a diagnosis of ankylosing spondylitis. So this entire concept came into picture so that we don't really depend only on the X-ray to reach a diagnosis of ankylosing spondylitis. So pre-radiographic stage would mean absolute activity, active AxSpA. And the moment we have radiographic stage, it would mean activity is there. It may not be there, but it has reached a stage wherein damage has also started. There are changes seen either in the SI joint or syndesmophytes in the form of damage related to the disease activity. How many patients with non-radiographic AxSpA move into the radiographic AxSpA stage? There are quite a few patients who would always remain in this phase. They would have inflammatory backache. The MRI may show sacroiliitis, and with NSAIDs, it may settle down to again reappear after some period of time. So a few patients would continue to remain in this stage even for indefinite period of time. And there are a few patients who would progress from non-radiographic to radiographic stage. So what is the rate of progression? Almost 10 to 20% of the patients move from non-radiographic stage to radiographic stage over 2 years. This rate is particularly high if the disease activity to begin with is high and if the CRP is high. So this is the same thing in a different form. Non-radiographic spondyloarthritis, axial spondyloarthritis. It can be the clinical arm wherein we saw the HLA-B27 with specific features of spondyloarthritis, or the imaging arm wherein MRI shows sacroiliitis. And this moves on to the radiographic stage. One radiographic stage can be radiographic spa without osteoproliferation, wherein the X-ray would show only changes of sacroiliitis but no syndesmophytes. And further still, one also has radiographic spondyloarthritis with osteoproliferation. So this is the stage wherein the patient has inflammatory backache and the X-ray also shows syndesmophytes. So non-radiographic axSpA, radiographic axSpA without osteoproliferation and with osteoproliferation. This is basically shows progressive damage related to axSpA, which is seen in the X-ray. So as I said, one of the biggest problems as far as ankylosing spondylitis or axSpA is concerned is a delay, diagnostic delay, not just in India, but across the globe, which is anywhere between 6 to 9 years from the onset of symptoms to the diagnosis. So many times the patient has, I'm sure all of you must be seeing this, the patient has already reached the stage of osteoproliferation or syndesmophytes by the time he comes to you and gets a diagnosis of ankylosing spondylitis. So we need to change this, and this is exactly the reason why this concept of non-radiographic axSpA and diagnosis of axSpA even without MRI with the help of HLA-B27 and the other clinical features came into picture. What are the consequences of delay? Again, this is something I'm sure all of you would know. Longer time to diagnose type as well. And the indirect human cost would be related to the psychological distress among family members and the patient as well. Coming to the clinical picture, what would it mean if the patient has a delay in diagnosis? Longer symptom duration is associated with greater progression of disease towards AS. In fact, you must have heard we always talk about therapeutic window or window of opportunity in rheumatoid arthritis. In rheumatoid arthritis, we diagnose early, and treat aggressively to get rheumatoid under control, because there is a clear evidence that there is a window of opportunity. If you diagnose and treat rheumatoid early and treat rheumatoid to target, then the outcomes are better. A similar picture is seen in ankylosing spondylitis as well. If there is increased disease duration, as you can see in this, up to 1 year, 3 years, as the duration of disease increases, the proportion of patients having ankylosing spondylitis features or syndesmophytes or sacroiliitis on MRI goes on increasing. The number of patients who remain only non-radiographic stage goes on reducing, and the number of patients or proportion of patients who go into radiographic stage, the damage phase, goes on increasing over a period of time as the disease duration progresses. Again, a similar picture. This is OASIS study, which is 12 years longitudinal data. Higher disease activity at baseline. As you can see, this is low. This is how the disease activity goes on increasing. So low disease activity, patients with low disease activity tend to progress less. As the disease activity to begin with increases, the progression of disease is higher. So it makes sense to diagnose these patients at the earliest possible time and ensure that we get the disease activity to as low as possible, so that progression over a period of time is low. So again, coming back to the same thing, let us diagnose these patients as early as possible, and let us ensure that their disease activity is controlled as early as possible to get better results in the long run and to avoid appearance of bamboo spine in the long run. One more data. This is The data from German spondyloarthritis inception cohort, high disease activity is associated with accelerated spinal progression in patients with early expa. So as you can see here, this looks at proportion of patients who have worsening of more than 2 points on MSSS. This is a score which looks at the radiographic progression. So if you have high disease activity, the chances that the radiographic progression will be more after 2 years is high. So these are the ASAS endorsed recommendations for early referral. Summary of the entire thing is we should be diagnosing these patients as early as possible, not just depend on the MRI or the X-ray for a definitive diagnosis. We have now other tools, other criteria to get a better early diagnosis. Treat them as early as possible and get their disease activity under control as early as possible. This takes us to the second. When we are saying we should diagnose early, we should treat early, what are the therapeutic options as far as spondyloarthritis is concerned? Again, let us concentrate main on the axial spondyloarthritis. What therapeutic options do we have? In fact, some years before, we were really short of options. Now we have multiple options in hand to treat these patients. So axial spondyloarthritis, basic non-pharmacological options, patient education, exercise. All of you, I'm sure, know about the importance of exercise in ankylosing spondylitis management. The first line of treatment is NSAIDs, and believe me, NSAIDs do put a lot of patients in the remission. Pure only NSAIDs and exercise is sufficient to put quite a few patients of early expa in remission. If NSAIDs don't work, what are the next options? Analgesics, opiates, local corticosteroids, we frankly don't use much in practice. Then comes sulfasalazine. As you can see here, sulfasalazine has been put mainly in the peripheral spondyloarthritis group. There are quite a few studies which we have been using sulfasalazine for a long time for axpa, but there are quite a few studies, a few of them will also look in a few slides, which show that there is not much role of sulfasalazine as far as pure axial spondyloarthritis is concerned. So if patient doesn't settle down with NSAIDs, then we straight on move on to biologics. NSAIDs, as I said, are quite effective in ankylosing spondylitis. As compared to other patients with mechanical backache, as you can see here, the response to NSAIDs as far as ankylosing spondylitis or axpa is concerned is significantly good. As you can see here, almost 78% patients improve significantly purely on NSAIDs. This is the data with diclofenac, aspirin, indomethacin, naproxen, phenylbutazone, and also with etoricoxib, which is very commonly used as when it comes to axpa. When it comes to sulfasalazine, as you can see here, somebody with peripheral spondyloarthritis, the response is quite okay. But when it comes to axial spondyloarthritis, when compared to placebo, so sulfasalazine, though we have been using for a long time, there is a lot of data emerging that shows that sulfasalazine may not be the best agent when it comes to treatment of axial spondyloarthritis. What are the current guidelines? The ASAS ULR guidelines, clinical diagnosis of axpa. The first line of treatment, as I said, is NSAID. Start a NSAID and titrate up to the maximum tolerated dose. If there is sufficient response in 2 to 4 weeks, you can continue the NSAID. If there is no sufficient response in 2 to 4 weeks, then move on to biologics, either TNF alpha blocker, interleukin 17 blocker, or JAK inhibitor. Current practice is TNF alpha blocker or interleukin 17 blocker. TNF, we have the maximum experience with TNF because they have been there for years together. So TNF remains one of the first choice when a patient of axpa doesn't sufficiently respond to NSAID. If the patient has history of recurrent uveitis or active IBD, monoclonal antibody TNF, which means basically etanercept is something that we don't use when the patient has recurrent uveitis or active IBD. The other TNF alpha blockers are preferred. If the patient has significant psoriasis, interleukin 17 blockers are preferred because they have a better effect as far as psoriasis is concerned. The other agent that is also available now is JAK inhibitor, but classically we would start with TNF alpha blockers because we have the maximum experience and clinical evidence as far as TNF alpha blockers are concerned. Coming to the various TNF-alpha blockers, infliximab, this was one of the, I'm sure everybody knows about infliximab. This was one of the earliest studies as far as infliximab in ankylosing spondylitis is concerned. Infliximab has clearly shown to be very efficacious as far as ankylosing spondylitis is concerned. The effect is quite rapid. Most of the patients, in fact, most of the patients, show the effect in reduction of pain and inflammation within few hours of the infusion itself. But if you look at the studies, BASDAI 20, you can simply take it as 20% improvement in the overall ankylosing spondylitis symptoms, and BASDAI 50 as 50% improvement. Even at 2 weeks, almost close to 80% of the patients have 20% reduction in the symptoms, and BASDAI 50% reduction, you can see. Even at 2 weeks, almost 40% of the patients have already reached BASDAI 50 endpoint. The CRP goes down significantly with infliximab, as you can see here, as against placebo. And the ESR as well goes down significantly with infliximab. This you can see as compared to the placebo, significant improvement there. NSAID reduction, since the inflammation gets controlled, reduction of more than 50% of the NSAID dose is significant with infliximab. And there are quite a few patients who go off NSAIDs as well. That again, clinically significant. Not just that, MRI inflammation, as you can see here, the Romanus lesions that you can see here, they have disappeared after infliximab infusion. So not just the symptomatology, but ESR, CRP, as well as the MRI lesions heal with infliximab. What about the long-term outcome? Even after 5 years, infliximab, most of the patients, or even at 5 years, 55% patients were still successfully being treated with infliximab. And even at the end of 5 years, there were no major safety concerns. One more study, ASSERT, again a similar picture, significant improvement as far as the clinical scenario is concerned. ASAS 20, significant improvement with infliximab. Early response, even at the end of 2 weeks, even as early as 2 weeks, you can see significant number of patients achieving ASAS 20, ASAS 40 criteria, which is almost as good as around 40% response. More stringent criteria, ASAS 5/6, significant response, and ASAS partial remission, again significant response even at the end of 24 weeks. BASDAI 20, BASDAI 50, BASDAI 70, significant response with infliximab, and there is sustained efficacy even at the end of 2 years. So infliximab is safe and effective in treating patients with ankylosing spondylitis. It decreases the disease activity, improves the physical function, mobility, chest expansion, quality of life, and productivity as well. What about the other TNF-alpha blockers? We have similar data with etanercept, response as early as 2 weeks with etanercept, and long-term data as well. Similar data with adalimumab in ankylosing spondylitis. As you can see, what is the difference between the various TNF-alpha blockers? As you saw, TNF-alpha blockers are one of the very effective agents as far as axial spondyloarthritis and ankylosing spondylitis is concerned. In fact, they changed the way we treated ankylosing spondylitis. There was a time when we didn't have any other option apart from NSAID and sulfasalazine as far as ankylosing spondylitis was concerned. And then came TNF-alpha blockers, which really changed the way ankylosing spondylitis was treated by then. What is the difference? Infliximab is an IV infusion. Etanercept, adalimumab, certolizumab, golimumab, all of them are subcutaneous injections. Etanercept is taken weekly, adalimumab is taken once in every 2 weeks, and golimumab is once a month. That obviously improves the patient adherence to treatment. So golimumab is a relatively newer, it has been there again for multiple years now. It is relatively new TNF-alpha antibody, which is administered as a monthly subcutaneous injection. GO-RACE, one of the main studies that got golimumab efficacy in ankylosing spondylitis in clinical evidence. As you can see here, the primary endpoint, significant number of patients achieving ASAS 20, ASAS 40, ASS 5 by 6, and even ASS partial remission. With golimumab, ASS 20, ASS 40, this is at the end of 24 weeks, significant patients achieving all these criteria and in fact even partial remission. If you look at BASDAI 50, again significant number of patients achieving BASDAI 50 at week 14 as well as week 24 with golimumab. Median changes when it comes to the measures from baseline to week 24, again significant reduction in most of the patient related outcomes: general assessment, total back pain, inflammation, and nocturnal back pain. Significant improvement with golimumab. It again has a rapid onset of action, as you can see here. Rapid onset of action, and difference is observed within 4 weeks after the first injection. Quality of life also improves significantly with golimumab. As you can see here, this is the placebo, and you can see here there is a significant difference in the quality of life as well in these patients. The sleep index, we particularly could look at the sleep index in ankylosing spondylitis patients because they do have nocturnal pain and disturbance of sleep because of the nocturnal pain. In golimumab, there is a significant difference, significant change in the sleep index as well. And efficacy is not just something that remains in the short run, but it is sustained even at the end of 2 years. This is a long-term extension study which looks at golimumab over a period of 2 years. So ASAS 20 and BASDAI both sustained improvement even at the end of, which is sustained even at the end of 2 years. And just the way we looked at infliximab, it does reduce the MRI-based inflammation as well. As you can see here, you can see the inflammation here on the MRI, the Romanus lesions, and they have decreased. If you look at the same patient's MRI, they have decreased and significantly gone by the end of week 104. So not just symptomatic improvement, the subjective improvement from patient's point of view, but also inflammatory markers and the MRI as well. So to conclude, golimumab, one, it has the advantage of once a month therapy, and it significantly improves the signs and symptoms of AS, quality of life of these patients, including the sleep, and its sustained efficacy is seen even at the end of 2 years. Thank you very much. Dr. Sagar, should we take any questions right now, or should I go ahead with my other presentation?
Sir, we can move forward to the second part of our session, and then as and when we get questions, I think we can continue at the later stage.
Okay.
Thank you.
Just give me a moment. Let me share the other presentation. Is my presentation seen full screen?
Yes, sir.
Perfect. So when it comes to biologics and newer molecules, we always wonder whether these are effective in our set of patients. Many of these trials are basically conducted in the Western world, and that data is extrapolated to Indian data. So as far as golimumab is concerned, do we have Indian evidence? Do we have Indian data? And what does the Indian data show? Let's have a look. I'm sure all of you would have this question in your mind because our patients are different as compared to the Western world. When it comes to rheumatoid, our patients are much younger as compared to the Western world. Our patients probably also have higher disease activity as compared to the Western world patients. This is what the general demographic data shows. And then it becomes interesting to see whether the newer biologics are equally effective and equally safe in our patients also. So this is the global clinical development program as far as golimumab across various rheumatological indications is concerned: ankylosing spondylitis, rheumatoid arthritis, and psoriatic arthritis. As you can see, there have been multiple studies to look into this. We would be looking at 3 particular studies that have included a good chunk of Indian patients. Let's have a look at these studies. First is golimumab analysis of global phase 3 trials. So this is looking at efficacy and safety of golimumab in Indian patients with rheumatoid arthritis, the subgroup data from Go More studies. This was an open-label, multi-center prospective trial of add-on golimumab in biologic-naive RA patients. 106 Indian rheumatoid arthritis patients were included in this, and the global study had 3175 patients. The main response criteria in this was achievement of good to moderate DAS28 ULR response. And as you can see here, majority of the patients achieved, as you can see here in the Indian data, almost 80% achieved response, good response in 22.9%, moderate response 57.1%, almost only 20% patients did not receive response. And this is comparable to the global data, not really very different from the global data. The same if the other criteria of DAS28 CRP ULR, these are basically DAS28 ESR or CRP ULR criteria are criteria that are used in rheumatology clinical trials to assess the response to therapy as far as rheumatoid arthritis is concerned. The second criteria of DAS28 CRP ULR is concerned, 87.6% patients achieved response, 47% almost achieved good response, and 40% moderate response. So at month 6, proportion of Indian and non-Indian patients achieving DAS28 ESR, DAS28 CRP as the remission were comparable. Incidence of all adverse events was lower in the Indian patients, and there were no deaths, tuberculosis or malignancy that were reported. We are very concerned about tuberculosis because India, as you all know, COX is something that is very rampant, something that is endemic, which is as against the Western population. So we, as far as TNF-alpha blockers are concerned, we are very concerned about tuberculosis. And good to see that this study did not show any case of tuberculosis during the entire clinical trial phase. So efficacy and safety results with add-on golimumab were consistent between RA patients from India and outside India, despite high baseline activity in these patients. In fact, if you look at the demography of the patients that were included from the Indian continent, patient group and the global, Indians had a higher disease activity, were younger, and most of the patients were on multiple DMARDs and higher, meaning there was a more proportion of patients who were on glucocorticoids. This is because most of the patients that were included were those who were refractory to multiple DMARDs. So, despite that, the data, efficacy data of patients from India and outside India were comparable. Coming to the second study, golimumab in RA, this is a phase 4 study in Indian patients. So, phase 4 prospective multi-center open label single arm study, 120 patients at 6 sites over 24 weeks, moderate to severe rheumatoid arthritis who were prescribed and initiated on golimumab 50 mg as per treating physician's clinical judgment. So the study intervention was golimumab 50 mg subcut once a month with methotrexate. And primary objective in this case was to assess the safety of golimumab, and other exploratory objectives were patient-reported outcomes like HAG Disability Index, FACIT, which specifically looks at fatigue in these patients, and satisfaction and user friendliness of the auto-injector. This also brings me to the point, most of the adalimumab, etanercept that are made by Indian companies do not have an auto-injector. So it is difficult for patient to take it or himself or herself. The patient has to go to a healthcare professional of the auto-injector, and injection site pain reactions were also assessed. So let's have a look at this. So patients who had RA who were being prescribed and initiated on golimumab were included in this study, and patients Obviously, those who are participating or planning to participate in any other interventional drug were excluded in this. As I said, as we saw in the previous study as well, we had younger patients, significant disease duration, almost 6.3 years of disease duration. And look at the number of patients who had number of failed DMARDs. 23% had one failed DMARD, where 36% had two failed DMARDs, and almost 38.3% had more than three or more than three failed DMARDs. Most of them were on methotrexate, most of them were on prednisolone. The reason for this is the absolutely refractory patients of rheumatoid arthritis were included in this study. And analysis-wise safety, the most common adverse effect was URTIs, pyrexia, and there were no cases of tuberculosis, no cases of malignancy, and no deaths that were reported in this study. This is again something that is important. No cases of tuberculosis, particularly in India, when it comes to anti-TNF management of ankylosing spondylitis. Patients before entering the study. Once upon a time, when TNF alpha blockers were new, when we screening the tuberculosis, the incidence of tuberculosis period of a lot of pictures screen these patients for initiating anti-TNF, and that's why the incidence after anti-TNF, either for rheumatoid or psoriatic arthritis or ankylosing spondylitis, has gone down significantly. What we also saw to begin with, apart from safety, there were other exploratory outcomes that were also to be seen in DI. This looks at the disability that a patient faces because of rheumatoid arthritis has changed significantly in this study. Facet F, which (64% of the patients were satisfied), and DAS 28 ESR, DAS 28 CRP, the efficacy, there was significant difference when it comes to these criteria as well. So not just this study not just told that golimumab is effective in our patients, safe in our patients, but also showed that patients are comfortable, satisfied with the auto injector as well. One of the biggest things is patient can take it himself or herself, and there are not many injection site reactions. That makes it very user friendly as compared to the routine PFS, the pre-filled syringes that we have that the patient cannot take himself or herself. So results indicate that golimumab in combination with the methotrexate appears safe as well as well tolerated in our patients. In our Indian set of patients, patients do have significant improvement as far as the disease activity is concerned, physical function and fatigue from baseline over time, and patients were very satisfied with the use of auto injector, and majority of the patients did not experience any injection site reaction. Lastly, let us also look at one more study which was published in JAPI, wherein golimumab in ankylosing spondylitis and psoriatic arthritis was evaluated. Till now, we have seen studies in rheumatoid arthritis patients. How about ankylosing spondylitis or psoriatic arthritis? This was a phase 4 interventional single-arm multi-center prospective study, 100 patients over 9 centers and over a period of 6 months. So adult patients with confirmed active SPA, spondyloarthritis, either ankylosing spondylitis or psoriatic arthritis were taken, and they were given golimumab once a month. This was the study design. If you look at the demographics, most of them being quite young patients, predominantly male. Concomitant medications that they were taking, sulfasalazine, folic acid, methotrexate, as would be in most of the patients, most of the general population as well. Not many of psoriatic arthritis being on sulfasalazine, because sulfasalazine is not used that frequently as far as psoriatic arthritis is concerned as it is in ankylosing spondylitis. and methotrexate that is commonly used when it comes to psoriatic arthritis. So these patients, apart from the concomitant medications, were also given golimumab. And if you look at the safety data, again, one of the most common side effects or safety issues that came into picture were nasopharyngitis and upper respiratory tract infection, gastritis, not something that is really serious or difficult to manage. 29% of the patients experienced more than one treatment emergent adverse event. Most of them were mild to moderate in severity. Most common were nasopharyngitis or URTI, pyrexia, cough, diarrhea. No deaths were reported and no malignancy or TB reactivation was reported in these studies. When it comes to the efficacy outcomes, again, significant improvement at week 14 as well as week 24 in ankylosing spondylitis patients. If you look at the efficacy endpoints, patient's global disease activity, significant improvement, total back pain improvement, BASP as well as inflammation which is taken from the BAS diet is again significant improvement at week 24. When it comes to psoriatic arthritis, again, when it comes to ACR 20, significant improvement at week 14 as well as week 24. Total joint count, swollen joint count, significant improvement, patient assessment of pain, patient global disease activity, physician global disease activity in HAC, again significant improvement at the end of 6 months. So subcute golimumab was well tolerated in Indian patients with no new safety findings or concerns. Safety profile of golimumab was consistent with something that was reported from global RCTs and the real world study, and it has sustained rapid, meaningful improvement in clinical outcomes of spondyloarthritis patients with AS or PSA. So, if you have to summarize, anti-TNF agents, one of the major agents when it comes to ankylosing spondylitis, as well as rheumatoid arthritis, psoriatic arthritis. Golimumab is an effective agent once a month, which makes it more user-friendly as compared to the other anti-TNF agents that are available. Risk of TB, malignancy, death, not really seen much in the Indian studies. It does show rapid, meaningful and sustained improvement, not just in the clinical efficacy parameters, but also physical function, fatigue and quality of life. Thank you.
Thank you, sir. Thank you so much for that fantastic presentation, for taking us through the entire landscape of spa management, including the management with conventional therapies and then moving on to the biologics. I think we can take the questions now. The first question is, sir, you spoke about that patient can remain on NSAID therapies for some time. So from your own clinical practice experience, for how long patient can stay on only NSAID therapies before moving to any kind of a DMARD or a biologics?
Yeah, NSAIDs, as I said during the session as well, they remain the first line treatment as far as ankylosing spondylitis is concerned. There is a significant number of patients who can go into remission with NSAIDs alone.
Hello. There's some technical issue. Sir, your voice is breaking. Can you please repeat?
Sorry. Can you hear me now?
Yes.
Yeah. As I said, NSAID does remain the first line of therapy when it comes to ankylosing spondylitis. So we do start, even as per the guidelines, we do start with NSAIDs. Go to the maximum tolerated dose. If the patient doesn't improve with at least 2 NSAIDs for a period of at least 1 to 2 months, then we think in terms of the next set of agents, that is the biologics or the JAK inhibitors. And technically, NSAIDs can be given in ankylosing spondylitis in the long duration as well. to keep the disease
Okay.
activity under control.
Okay. Sir, in terms of the extra musculoskeletal manifestations, do you see them as a very important determinant of choice of biologic while you prescribe these therapies to your patient? And how do you select these different biologics according to the presence or absence of extra musculoskeletal manifestations?
Yes, absolutely. This is in fact very important. Apart from just the disease activity of ankylosing spondylitis or the spondyloarthritis, we have to look at the additional features that they have, and to some extent also the comorbidities that they have to take a good choice of biologics. So when it comes to axial spondyloarthritis, if the patient has uveitis, then monoclonal antibodies are preferred, something that we discussed during the session as well. Etanercept is not the preferred agent. The monoclonal antibodies become the preferred agent. When it comes to inflammatory bowel disease, again, etanercept does not remain the preferred agent. The monoclonal antibodies, particularly infliximab, is much better as compared to other biologics. When it comes to inflammatory bowel disease, again, interleukin 17 blockers again are not used. It is mainly the anti-TNF monoclonal antibodies that are used. If somebody has significant psoriasis, in that case, interleukin 17 has a preference over the other agent. And the second thing I spoke about is the comorbidities as well. Comorbidities have particularly come into picture after introduction of the JAK inhibitors. So elderly patients having diabetes, hypertension, ISD, again anti-TNF agents.
Hello.
Yeah, sorry, some issue again at my end. Sorry.
So if you can just
Hear me, Dr.
repeat
Sagar?
last
Yeah.
20 seconds.
Yeah. When it comes to comorbidities, in fact, the comorbidity issues have come into picture after the introduction of the JAK inhibitors. So elderly patients, those having diabetes, hypertension, cardiovascular disease, ISD, the choice of agent again becomes anti-TNF as compared to JAK inhibitors, because JAK inhibitors have been known to increase the chances of cardiovascular events in these patients.
Thank you, sir. Thank you so much. Sir, one question. Does inadequate control or lack of early initiation of these DMARD therapies or biologic therapies puts the patient at increased risk of development of comorbidities like cardiovascular or renal comorbidities?
Yes, definitely yes. There is a concept that uncontrolled inflammation ultimately can lead to increased cardiovascular events. Because it is uncontrolled inflammation, the CRP persistently remains high, and that uncontrolled inflammation in the long run has been shown to increase the risk of cardiovascular events. So it makes sense, irrespective of the type of inflammation, irrespective of the type of inflammatory arthritis, it makes sense to control the inflammation as early as possible and to ensure that it remains in remission in the long run. Secondly, coming to the renal, I am sure all of you would accept and understand long-term uncontrolled activity would mean long-term NSAID usage, would mean ultimately increased chances of renal complications.
Right. Thank you, sir. Sir, next question is, now we also have a lot of clinicians who have joined for this meeting who wants to use biologics for their ankylosing spondylitis patients, but there is a clear lack of awareness, understanding regarding how to initiate these biologics, especially in terms of the infections, what pre-treatment assessment need to be done. So can you please take us through how do you assess your patients before putting on any biologic?
Yeah, see, biologics are a double-edged sword. They are very effective. They have changed the way we treat inflammatory arthritis. We have numerous options now available for ankylosing spondylitis. But what is also important, the other side of the coin is they can also, being immunosuppressants, they obviously can increase the risk of infections in the long run. So before biologics are started, we have to screen. One is all the basic reports, CBC, SGOTPT, LFT, RFT, the basic reports. Apart from that, there has to be screening for latent tuberculosis, particularly for the anti-TNF agent and the JAK inhibitors. So we do MAN2 test in each and every patient, a TB gold in each and every patient, X-ray chest, and a clinical examination to look for tuberculosis which may be active in that patient. If the patient has active TB, obviously there is no question of biologics, treating the tuberculosis first, and then only we can think in terms of biologics. If the patient has latent tuberculosis, as will be shown in a positive MAN2 or a positive IGRA test, then we need to treat the latent tuberculosis and then start with biologics. So as I said in the session also, when the biologics were first introduced for rheumatoid arthritis and ankylosing spondylitis, we didn't have much experience as far as latent tuberculosis and the effect of anti-TNF or the biologics is concerned, and there was a high incidence of reactivation of tuberculosis. But since then, we have come a long way. We screen each and every patient who is supposed to take a biologic for latent tuberculosis, for other infections, and then only we go ahead with the biologic. It is a good idea to go ahead with vaccination also prior to starting a biologic, if you are anticipating biologics in the long run.
Thank you, sir. Thank you for taking us through the importance of screening, especially in terms of preventing the chance of development of tuberculosis in our patients. Thank you. So one more question is related to adherence for these biologics. So how long these biologics should be continued, and do you see any long-term complications of it?
See, technically, biologics, there is no ceiling to the duration of a biologic. It's not that they have to be continued for 1 year, 2 years, 3 years, 5 years. It's nothing of that sort. So as long as they are required to keep the disease activity under control, in remission is the duration of a biologic. In Western world, they are given indefinitely because there is a lot of data available which shows that if the biologics are tapered, there are chances of recurrence of the disease activity or a flare. In Indian setup, what happens so many times for practical considerations, for financial considerations, we do tend to keep, a shorter duration of biologics, something like 6 months, 1 year. But if you ask me technically, if the patient affords, you should be keeping it in the long run, as long as it is required to keep the disease activity under control. If the patient remains in deep remission for a good period of time, say 1 year, 2 years, you can taper the biologics slowly. If there is a flare, obviously go back to it. If there is no flare, you can either taper the dose or you can increase the duration. But obviously keeping in check, keeping the disease activity strictly monitored.
Okay, thank you, sir. Sir, one question is regarding the use of DMARD therapies, the conventional DMARD therapies. Now, can they be used along with biologics in our patients of ankylosing spondylitis? And what's the role of methotrexate?
Yeah. Spondyloarthritis, as we just saw, there is a group that is purely axial spondyloarthritis, and there is a group which would be peripheral spondyloarthritis. So peripheral spondyloarthritis, sulfasalazine definitely has a role to play. Methotrexate has a role to play. But when it comes to purely axial disease, there is no role of methotrexate. And sulfasalazine, again, there is more and more data emerging which shows that even sulfasalazine probably does not have any or much role to play when it comes to axial spondyloarthritis. So peripheral spondyloarthritis, we would keep methotrexate, sulfasalazine. If things don't settle, add a biologic. And later on, maybe once things are into deep remission, remove the biologics, withdraw slowly, ensuring that the disease doesn't flare, and continue with the DMARDs. When it comes to axial spondyloarthritis, there is not much role of methotrexate and sulfasalazine. So DMARDs may not be there along with a biologic. It would be biologic alone to control the disease activity, biologic alone with exercises, and if required, NSAID.
Okay. Thank you, sir. Sir, one last question is through your presentation, we saw that there is this new data of golimumab which has come up, especially in the Indian patients. So with this, all of these data points coming in, can you just help us understand what are the patient profiles where you would go for golimumab vis-a-vis any other biologic?
in rheumatoid arthritis, there is no particular patient profile, but advantage with golimumab, meaning there is no particular feature in wherein you would say that this is the preferred agent. But advantage of golimumab is once a month therapy, which makes it very easy as compared to other biologics because etanercept has to be taken once a week, adalimumab has to be taken once every 15 days, and infliximab requires IV infusion, admission, visit to a hospital. So golimumab that way makes it easy. Second, there is an auto injector available, so patient can take it himself or herself. This is what makes it preferable when it comes to looking at the entire thing from a patient's perspective. When it comes to ankylosing spondylitis, after NSAIDs, traditionally TNF alpha become the next level of therapy, and in them again golimumab comes up with the same advantages. And as far as the Indian data is concerned, we just saw that there are not, meaning the data did not show any reactivation of tuberculosis. So that's again something that is heartening to know vis-a-vis other biologics.
Thank you, sir. Thank you so much for first of all taking a time out from your busy schedule to accept our invite and to help our clinicians understand the entire landscape of management of axial SPA. I think all the queries which were raised by our attendees have been addressed. Thank you so much, sir. And just to inform you, more than 100 clinicians from across the western part of India have attended the session. Thank you so much. I think the experience and the expertise that you have shared will help us in terms of creating awareness for axial SPA management, especially along with the biologics. So thank you, sir. Thank you so much for your participation. And also a special thanks to our attendees who could take out time from their schedule to attend this event. Thank you. Thank you so much. So with this, thank you, sir.
Thank you, Dr. Shashank, and thank you, Dr. Sagar, for hosting the event. And I would like to sincerely thank you all the participants who have made this event successful. Thank you, everyone. Good night.
Thank you. Good night.
Thank you, everyone. Thank you. Good night.
Recording.